Naravi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naravi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naravi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naravi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naravi Hospitals is a completely paperless and filmless hospital. The Naravi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naravi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naravi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 6 tiers with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naravi Hospitals is more than a hospital. It is an experience.
A warm welcome to all our panelists and participants who have joined this Sunday morning's webinar, which is part of Healthy India, Happy India initiative by Naruvi Hospitals, Vellore in collaboration with The Hindu. My greetings to all of you as we celebrate the 76th Republic Day and bring you this episode, the third in a series of 15 that are aimed at inspiring and promoting wellness. Our panel of experts here today will discuss thyroid disorders, prevention, and early detection. Thyroid disorders are mostly linked to genetic factors and generally are not preventable. However, for better thyroid health, early detection through regular checkups and blood tests is crucial. I will first invite Dr. Aravinda Nair, Consultant General and Endocrine Surgeon, Naruvi Hospitals, Vellore, to give a general introduction to the topic. And for this brief introduction, Dr. Nair retired from Christian Medical College, Vellore as professor and head of endocrine surgery department after 30 years of service. He has also been emeritus professor at the Tamil Nadu Dr. MGR Medical University, Chennai. He is member of multiple professional associations, recipient of several awards, and has more than 60 publications in peer-reviewed journals. After this brief introduction by him, we will hear the remaining three panelists also give their presentations, and then Dr. Nair will again come back with his talk on malignant conditions in thyroid before we take the questions from the audience. So it's over to you, Dr. Nair.
Thank you, Soma. Good morning and happy Republic Day. At the outset, I would like to thank the Hindu and the Naruvi Hospital Group for this webinar, Healthier and Happy India. Better health choices and a healthier lifestyle. Today, I would like to give a bird's view about thyroid disorders, and then we'll go on to the various aspects by my other colleagues. The thyroid gland slide. The thyroid gland is a endocrine gland which is situated in front of the neck. It has a right and left lobe joined by the isthmus. It weighs about 20 to 25 grams. And the word thyroid is derived from the Greek word thyrus, which means a shield. The thyroid gland produces thyroxine, which is extremely important for the normal function of the human body. When the thyroid function is normal, we call it a euthyroid state. If it is low, it is hypothyroid, and if it is high, it is hyperthyroid. The swelling of the thyroid gland is a very common occurrence. Actually, if you look at a population survey, 40 to 50% of the population may have a thyroid nodule, but only a small percentage get detected. And with this introduction, I would like Dr. Soma to take over and continue the session.
Thank you, Dr. Nair. I'm not Dr. Soma. And we'll now move on to our next speaker, Dr. Sai Krishna Chaitanya P. He is consultant endocrinologist. He did his MBBS and MD from Kurnool Medical College and senior residency from Sri Venkateshwara Institute of Medical Sciences, Tirupati. He worked as consultant endocrinologist at KIMS Hospital, Ongole, before joining Naruvi at Vellore. He will speak on thyroid function tests, hypo and hyperthyroid conditions, including thyroiditis, diet, and thyroid. Over to you, Dr. Chaitanya.
Thank you for the kind words. First of all, I would like to thank Hindu Group as well as Narvi Hospitals for giving me this opportunity. And I would like to say Happy Republic Day to our audience. And today my topic is the most common topic, that is the diagnosis of thyroid disorders. Hope my slides are visible.
Yes, sir.
So nowadays, the thyroid disorders, thyroid profile has been a part of many of the packages. So everyone needs to know about what is thyroid profile. So normally in every package we have a thyroid profile, which is also called as thyroid function test. What are the components of the thyroid function test? You have a TSH, which is called thyroid stimulating hormone. You have a T3, which is triiodothyronine, and T4, which is tetraiodothyronine or thyroxine. So these are the three components of the thyroid function test. In the coming slide, we will know which hormone is produced from where. So this is the normal hypothalamo-pituitary axis, what we call it as pituitary thyroid axis. Hypothalamus is a part of the brain from where we have the release of the hormone called as thyrotropin releasing hormone. This thyrotropin releasing hormone acts on the pituitary gland and it will stimulate the production of the TSH. So the thyroid stimulating hormone which you have in the thyroid profile is produced by the pituitary gland. It is not a product of the thyroid gland. That is what I want to reinforce here. And this thyroid stimulating hormone, which is produced by the pituitary gland located at the base of the brain, which stimulates the thyroid gland to produce thyroid hormones, which are nothing but T4 and T3. So basically the thyroid hormones are T4 and T3. TSH is not a thyroid hormone. It is a thyroid stimulating hormone. It is produced by the pituitary gland, which is located in just below the brain. Okay. So that is what I want to tell here. So it is produced, TSH is produced by the pituitary gland. And T3 and T4 are the main hormones produced by thyroid gland. T3 is the biologically active hormone and 90% of the thyroid gland secretion is composed of T4 and majority of the T3 is formed by the peripheral conversion. So when you look at the hypothyroidism, what is hypothyroidism? So you can see here, this diagram clearly depicts that. So what is a normal function? Normally, if you take this small circle as a pituitary gland, this pituitary gland produces TSH, thyroid stimulating hormone, and turns on the thyroid gland. So whenever it turns on the thyroid gland starts producing T3 and T4. So whenever the blood levels are adequate, what happens is the T4 goes and turns off the pituitary. This is how the tight balance is maintained in the body. So the TSH and T4 are tightly regulated. So whenever the T4 is more adequate for the body, it will go and stop the production of the TSH. Whenever the T4 is less, it will turn on the pituitary and it which produces thyroid stimulating hormone. So this is how the tight balance is regulated in the body. Whenever any abnormality occurs, for suppose if you take the condition called as hyperthyroidism, what happens in hyperthyroidism? In hyperthyroidism, the thyroid gland here is functioning autonomously. It is functioning by itself. So it lost its regulation by the pituitary gland. So the control of the thyroid gland by the pituitary gland is lost here. That's why it is shown as a dotted line. So what happens? The thyroid gland starts producing autonomously the thyroid hormones, that is T3 and T4. So the body is in a situation where the T3 and thyroid hormones are in excess. These excess thyroid hormones go and suppress the pituitary gland. So the TSH is reduced. So in this condition of hyperthyroidism, what happens is the high T3 and T4 produced by the thyroid gland will suppress the thyroid stimulating hormone. So you have a low TSH and a high thyroid hormones. So that is what is hyperthyroidism. Most of the patients come to us with a TSH report of low TSH and comes with and says that our thyroid hormones are low. So, but it's the opposite. Whenever the TSH is low, it suggests that the thyroid hormones are in excess. These excess hormones are going and suppressing the thyroid stimulating hormone produced by the pituitary gland. So the low TSH suggests excess of thyroid hormones. And the other condition is a hypothyroidism, where the thyroid gland is inactive. So the thyroid hormone production by the thyroid gland is reduced. Whenever thyroid hormone production is reduced, then the effect of negative feedback effect of the T4 on the pituitary gland is lost. So what pituitary thinks, it starts producing more and more of thyroid stimulating hormone. So whenever you have a low amount of thyroid hormones in the circulation, there will be high production of thyroid stimulating hormone by the pituitary gland. So the high TSH means that the thyroid hormones in the body are low. So this is what is the interpretation of the primary hypothyroidism. There is a rare condition called as secondary hypothyroidism, so which is of interest to the endocrinologist. So where you have the hypothyroidism, the thyroid hypofunction is because of the hypofunctioning of the pituitary gland. Here, both the hormones are low. So the most common conditions is the primary hypothyroidism, which we are going to think of it. So there are two conditions here. In the hypothyroidism, in mild cases, the T3 and T4 hormones can be normal. the earliest change would be high levels of the thyroid stimulating hormone. So there is one more interesting condition called as thyroiditis. Thyroiditis refers to the inflammation of the thyroid gland. Here the thyroid gland is inflamed. So there are many varieties of thyroid gland, but the inflammation of thyroid gland here is what I would like to say is it is a transient one. So whatever the changes are occurring at thyroid function tests are transient. So they can return to normal. So this is what I want to reinforce while discussing this topic. So there are variety of thyroiditis. Hashimoto's thyroiditis, which is the most common, also called as autoimmune thyroiditis. And painless and postpartum thyroiditis, subacute thyroiditis, which is a painful thyroiditis. When you look at the thyroiditis stages, they encompass all the three phases. One, initially, you have in the first 1 to 3 months, you have a hyperthyroid phase where you have excess of the thyroid hormones. And the second 4 to 8 months will be the hypothyroid phase where you have low thyroid hormones, followed by normalcy. So, this is what. So, a patient who is suffering from thyroiditis need not worry and need not require lifelong medication. So the identifying the cause is most important. So in the thyroiditis, the patient may return to normalcy after 1 year. Coming to the most common form of thyroiditis, Hashimoto's thyroiditis. It is autoimmune thyroiditis. Autoimmune in the sense our immune system detects our body enzymes as foreign and causes a destruction of them, which causes the destruction of thyroid, resulting in the hypothyroidism. Most of the times, it is asymptomatic or presents as hypothyroidism. And subacute thyroiditis, we have already discussed, it is a post-infective sequelae. It is painful. It is a painful condition. So, last but not the least, so we are worried who should get tested. Okay, most of the patients who can be diagnosed as a part of health packages, that is okay. But who should suspect and who should get tested? When there is a gradual weight gain or a weight loss. Weight gain is seen in case of hypothyroidism, weight loss is seen in case of hyperthyroidism. An increased lethargy and sleepiness. So, having no interest in the work and want always increased sleep, and all these things suggest hypothyroidism, whereas a hyperactivity suggests hyperthyroidism. And the alteration in the bowel habits, having constipation, this is a feature of hypothyroidism, whereas a diarrhea is a feature of hyperthyroidism. So alteration in the bowel movements are also suggest thyroid disease. And coming to the women, menstrual irregularities and palpitations is a feature of hyperthyroidism. When you look at the children, the delayed growth when compared to peers is a situation where we need to suspect. So these are the areas where we need to suspect hypo and hyperthyroidism, and these are the people who should get tested for thyroid function test. Thank you. Thank you, one and all.
Thank
Over to you,
you,
madam.
Dr. Thank you, Dr. Sai, for the informative presentation. We will move on to our next speaker, Dr. Pooja Ramakant, Professor, Endocrine Surgery Department at King George's Medical University, Lucknow. Her qualifications is one long list of letters from MS, MCH, DNB, FRCS, FSCS, FISS, FARIS, FIAES, and MNAMS, which I think all doctors and medical students would easily identify. Dr. Pooja has won many national and international awards and titles at conferences. She was the Dean of Innovation Cell at KGMU and also an ex-faculty at CMC Vellore, among other things. She will speak on thyroid disorders in pregnancy. Welcome, Dr. Pooja.
Thank you. And I shall be talking about this important topic because it affects a lady as well as the baby when the lady is pregnant. So this is a very important topic. And in pregnancy, there are a lot of changes which happen, which mimic thyroid disorders. So it's difficult to pick. So can we move the slides? So thyroid is the second most common disorder after diabetes in pregnancy if you see among the list of endocrine disorders. And as has been talked about, it can be either hypothyroidism, which means less production of thyroid hormones, or hyperthyroidism, which means increased than normal production of hormones, or thyroid itself gland can develop a nodule, which may be benign or cancerous. Or if the lady is lactating, breastfeeding, in that time, postpartum thyroiditis may happen. So it continues, these physiological changes continue for at least a year after pregnancy and delivery. We may not be able to prevent these autoimmune disorders like Hashimoto's thyroiditis. However, we need to pick up very early to treat them. What happens to the mother and to the baby? The problem is the baby is not able to produce its own thyroid hormones in the first 3 months of pregnancy and is dependent on mother's thyroid hormones. So if mother's hormones are disturbed, it affects directly the baby. Baby starts producing later on, but still is not sufficient enough to function on its own. And in pregnancy, what happens is the problem is there are two hormones which mimic thyroid hormones. One is human chorionic gonadotropin (HCG) and estrogen. So that causes physiological changes which mimic the increased thyroid hormones and difficult to differentiate the two. So how to test it? It's very common and very easily available thyroid function test, which has been recommended to be done in all ladies who are pregnant by the Endocrine Society of India, and especially for those who have either symptoms of hypothyroidism or any history of thyroid disease, had been taking medications in the past, or history of infertility or recurrent miscarriages or other endocrine problems like diabetes, rheumatoid arthritis, lupus, or other things. So important for women is that they need to tell all these histories in their initial prenatal visit so that the gynecologist can have an endocrine evaluation done to pick up any dysfunction. So early detection is for looking for the symptoms. As has been previously told by the previous speaker, hypothyroidism is all lethargy, weakness, body swelling, and hyperthyroidism is all increased sweating, palpitations, weight loss. So all these things can be known and picked up early if we know these problems. So how to prevent it? Prevention is by avoiding goitrogens, which means food which causes goiter like cruciferous vegetables, cauliflower, avoid processed food, maintain a healthy body weight, do a mild exercise, ensure that you take an iodized salt and all the minerals like selenium, zinc, reduce stress, no smoking or alcohol or any radiation while being pregnant or even after delivery. So workup includes thyroid function tests. We have to do free T4, T3, and TSH, which may not be done in a single setting. If it is abnormal, it needs to be repeated every month in pregnancy as the changes alter with the pregnancy moves. And the TPU antibodies and TSH receptor antibodies may also need to be done along with that. If there's a nodule, we may need to do an ultrasound or the FNAC of the nodule. So the management involves taking medications. In hypothyroidism, we give levothyroxine, which is safe for the baby as well as for the mother. In hyperthyroidism, we give antithyroid medications like propylthiouracil or neomercazole, which are also safe. So what precautions a lady has to take if she's taking these medications while she's pregnant? She has to notice she doesn't develop any side effects like jaundice, abdominal pain, fever with sore throat. If these things happen, she has to report to the doctor immediately. So the other question is it safe to take these medications while she's breastfeeding? Yes, definitely. We prescribe these medicines at a low dose, not at a high dose, and we keep checking thyroid functions every month so that we may need to adjust the dose if they are increased or reduced. So if somebody develops a nodule in the thyroid gland, we have to look for if it is benign or cancer in pregnancy. If possible, surgery is needed. We do in the second trimester, in the middle 3 months, or we try to postpone it and do after delivery. While the lady is pregnant or is breastfeeding for 1 year, we don't do radioiodine scan. That is contraindicated. So to summarize the important points, prevention is at 3 levels. Primary prevention, we ensure we don't have deficiency of minerals like iodine and other minerals so that doesn't precipitate the dysfunction of thyroid hormones. Secondary prevention is to screen to do the thyroid function test. And tertiary is if it is abnormal, we need to treat it. So we need to know these signs and symptoms so that we have effective strategies for early detection. And if there's a problem, we manage it because we need to have improved outcomes of pregnancy, healthy baby, and healthy mother both. With this, I thank you.
Thank you, Dr. Pooja. We move on to our next speaker, Dr. Tushar Yashwant Sonavane, Consultant General Endocrine and Laparoscopic Surgeon at Naruvi, Vellore. He has 17 years of experience behind him, and after completing his MBBS from Pune University, Dr. Tushar did his post-graduation from National Board of Examination at HN Hospital, Mumbai, and worked in Mumbai before moving to Vellore. He will now speak on benign thyroid tumors. Over to you, Dr. Tushar.
Yeah, thank you, Soma. Good morning, everyone. First of all, I would like to thank Hindu and Naravi Hospital for giving me this opportunity. And I would like to wish all of our audience Happy Republic Day. Soon I'll be sharing my slides. I hope the slides are visible to everyone.
Yes, sir. Yes, sir.
Yeah. So today I'll be discussing about benign thyroid swellings. So the word benign itself means that the swelling is not cancer or not malignant. So the following slides, we will see what these swellings are, how they look like, how the patient presents with these swellings, what the doctors, how they evaluate these patients, and which of these swellings we should be worried about, and which of them need evaluation, and which of them need surgery, or else whether they can be observed. So in the beginning, you can see in the mid of the upper diagram, you can see a normal thyroid gland, which has two lobes and a small pyramidal lobe in between. On the left side, you can see a uniform enlargement of the complete gland. So what we call it as hyperplastic goiter or diffuse goiter. In the middle part, you can see only the left side has a small nodule. So we call it as a solitary nodule or a single nodule goiter. On the right side, you can see multiple of these nodules spread out in whole of the gland. So we call it as a multinodular goiter. To look at the clinical pictures, you can see this is a clinical picture of a diffuse hyperplastic goiter. You can see there's a uniform enlargement of the whole of the gland. So this picture, you can see there is only an enlargement of the left side of the gland. And you can see in the picture also, there's only a single nodule is there in the left lobe. So we call it as a solitary nodule of the thyroid gland. In this picture, you can make out the whole of the gland has multiple nodules. Especially this, we call it as a multinodal goiter, and most of them are colloid goiters. This is another type of thyroid swelling. You can make out the swelling in the lower part of the neck with where the thyroid is hyper functioning. That means it's producing more hormones, and the patients will have typically large eyes. You can see in this picture. So that is called as thyroid swelling with thyrotoxicosis. Just to give a brief idea about these swellings, the first one is simple goiter. Simple goiter is usually caused because of the iodine deficiency, because of lack of iodine in the food and water. Usually it is found in areas where you get a water source from mountains. The another type is physiological goiter, as madam has already described. During puberty and pregnancy, during this is the time when the stress is more, the body needs a lot of hormones, so the thyroid gland gets stimulated more to produce more hormones. So in these conditions, the thyroid swelling, thyroid can get enlarged and produces a thyroid swelling. So that is a physiological goiter. Multinodular goiter is usually the last stage of diffuse hypoplastic goiter, which will have multiple swellings. There are another types of swelling, thyroid swellings, which we get due to some genetic defects in the mechanism of synthesis of the thyroid hormones, in which case thyroid also can get enlarged in size. The other one is, as we saw the picture earlier, a toxic goiter, where the thyroid is functioning more, we will have diffuse thyroid swelling. Sometimes the whole thyroid gland itself will be hyper functioning, or sometimes there is a small nodule alone which will be functioning more and producing more thyroid hormones. In that case, we call it as a toxic adenoma. The other types are like autoimmune thyroiditis, which Dr. Saiser has already talked about, where the thyroid function is getting, thyroid hormone is getting stimulated by the antibodies. And in some rare infections also, we get this benign thyroid swellings. So how does the patient present to us usually? Usually when the patient is, for example, if they are shaving and looking at the mirror, so they may notice a swelling in the mirror, or when they are using some sunscreen lotions or something. Very commonly, some friend or the relative of the patient can notice it and bring it to the notice of the patients. That's how they find out that there is a swelling in their neck. With the recent availability of more and more investigations, imagings, more often we are finding this swelling incidentally, which for many times patient is doing the test for some other reason, like for some neck pain or some other reason, and we find this thyroid swellings on the routine imaging. Once these patients come to doctor, usually we take a history of any previous exposure of radiation in past, like in childhood or in adolescence, any family history of thyroid tumor. So these history is suggestive of possibility of malignancy in the thyroid. So this is very important history we take from the patient. We ask them about their appetite, sleeping pattern, weight gain, loss, any intolerance to heat or cold. That usually gives a history, idea whether it is hypo or hyper functioning. History of change in voice, difficulty in swallowing, any chronic cough, any breathing difficulty is suggestive of the local compression onto the windpipe or into the esophagus. There is a food pipe. So that is an important history we ask the patients. Clinically, when the patient comes to us, we check their pulse, blood pressure, look for dry skin, any eye signs, any generalized edema, body like puffiness of face or the body. We look at the thyroid swellings. The thyroid swelling usually will move up when the patient swallows. So we usually look for that. We'll make the patient look up and swallow. So if there is thyroid swelling is there, it will move up with deglutition, that is swallowing. We look for the lymph nodes also in the neck. How do we evaluate them? As Dr. Sai sir has already described about thyroid function tests. So these are the TSH, T4 and T3 along with antibodies we do as a routine checkup. Ultrasound is a very good investigation. It's very widely available, non-invasive, painless, and it helps us to do correct FNSCs, that needle tests. It also gives us information about the lymph nodes in the neck. As per the ultrasound, we can classify whether this swelling is benign or whether there's chance of this swelling being cancer. So that gives a very good idea. And the last FNSC. FNSC is a fine needle test which you do from the nodules, the suspicious nodules, and that gives us idea whether it's malignancy or not. So regarding preventing measures of these benign swellings, as Madam also has described, so the simple goiters can be prevented by introduction of iodized salt in the community. Early therapy of thyroxine, that is thyroid hormone, in cases of simple goiter can regress the swelling. So these are the preventive measures which you can take for this benign swellings. Most of the multinodular goiters which are asymptomatic and they can be managed by just serial ultrasound, they can be followed up, and most of them they do not need operations. So that is a good thing. So coming to what swellings which we should be worried about, or which of them need treatment, or we have to look into it. So those whose FNSCs are suspicious of malignancy definitely need some therapy, many times a surgery. Tracheal compression, as I said earlier, the history of any difficulty in swallowing, change in voice, the thyroid swelling may be compressing the windpipe, or sometimes the nerve which is supplying the windpipe. So that is an indication of surgery in these cases. And of course, the cosmetic reason, or where the patient wishes, means many times patient, though they will be benign and not causing much of trouble, and we know that it will not cause much trouble to the patient, still the patient wants that to be removed because that will be seen as an abnormal thing. So for cosmetic reasons also, we do thyroid surgeries. Okay, so what to summarize things is most of the thyroid swellings are benign and can be followed up if we do proper investigations and make sure they are benign. But when we need surgery for these benign swellings, options will be like partial removal of the gland or the total removal of the gland, which we call it as hemi or a total thyroidectomy. With this, I will conclude my presentation. Thank you.
Thank you, Dr. Tushar, for your presentation. And I'll now request Dr. Nair for his talk on malignant thyroids. And meanwhile, I also would like to request our audience to start posing their questions to the panelists in the Q&A box. Over to you, Dr. Nair.
Thank you. First. Next. My slides are visible?
Yes, sir.
Unlike all other cancers, cancer of the thyroid is one of the cancers that can be cured completely in 90% of the patients. So very often the very mention of the word cancer puts people off. I wish to highlight here that thyroid cancer is a unique cancer which can be cured by treatment. And please remember, cancer of the thyroid is not a death sentence. Thyroid swellings can be asymptomatic, as my previous speaker has mentioned, or seen when somebody watches you swallowing, they say, I can see some nodule in your neck. And some of them can present with a discomfort in the neck. And very often, as we have seen earlier, incidentally on imaging like ultrasound or CT is done left, right, and center nowadays. And then, of course, some of them can present with pain or change in voice or difficulty in swallowing and sometimes difficulty in breathing. Malignant lesions are usually equally common in men and women, although we know thyroid swelling per se are much more commoner in women than in men. Now, just to show you an illustration of how they can present, sometimes they can present like this young lady with a solitary thyroid nodule. A solitary thyroid nodule on one side. And sometimes they can present as a bilateral swelling, which is known as the multinodular goiter. And sometimes they'll present that the moment you see the patient, you know this patient has a malignant swelling because you can see that there is a swelling in the thyroid and there are multiple swellings on the lateral side of the neck. These are all lymph nodes. So this swelling, this thyroid is a malignant swelling. From the thyroid, it has spread to these nodes. And sometimes you will find the patient presents with something in the head and hardly anything visible there. This is a typical type of cancer which is known as a follicular, which spreads by the bloodstream. So patient may present with a pulsatile swelling there, which is a secondary deposit on the skull. And the basic swelling may not be very large at all. Now, what are the risk factors for thyroid malignancy, the thyroid? Most important is if you see a thyroid swelling in a child or young adolescent person, you should view it with suspicion. Again, men above 40 and women above 50 who develop a thyroid swelling and which progresses quickly, we know this could be a malignant swelling. Then the usual symptoms of malignancy like weight loss, history of radiation exposure and a family history of thyroid. Certain thyroid malignancies run in families, like some papillary carcinoma thyroid or medullary carcinoma thyroid. These run in families. So if there is a family history, we always have to be very careful with such patients. And any patient who has a thyroid swelling for a long time, like a multinodular goiter may be there for 10 years, and suddenly if it enlarges in size rapidly, we know that that swelling is transforming into a malignant swelling. And again, patient says, I had only a single swelling, and now I'm getting multiple swellings on either side. Then you know the patient is also developing lymph nodes. There is a condition known as multiple endocrine neoplasia, where a patient may have 2 or 3 endocrine malignancies at the same time. That is, they may have a thyroid tumor of the thyroid, they have a tumor of the adrenal gland, and they may have a tumor of the parathyroid. So one of them may present earlier. Sometimes it may be an adrenal tumor which can present with hypertension, and you examine or evaluate, you find they have a thyroid swelling also. Radiation during childhood, which is very common still in many places, where for conditions like neuroblastoma, Wilms tumor, lymphomas, children get radiation as part of the treatment, and 20, 30 or 15, 20 years down the line, they develop a thyroid malignancy. Iodine deficiency also is a factor in thyroid malignancy. Oral contraceptives and lifestyle conditions like obesity, smoking, alcohol also are risk factors for malignancy. Now, how do we evaluate once a patient comes with a thyroid swelling and you suspect this could be a malignant lesion? Most important is a very good clinical examination. Look whether the swelling is on one side or both sides, or whether there are any lymph nodes in the neck. These are very small things which you have to do a very careful palpation. Then again, once you find there is a thyroid nodule, you always first go for the ultrasound, which is easily available, non-invasive, and patient doesn't have any problem going in for an ultrasound. And once the ultrasound picks up a lesion, then if we suspect a malignancy, we do what is known as a fine needle aspiration cytology, where we put a fine needle into the nodule and take out some cells and examine it under the microscope. Sometimes the FNAC may not be giving a good picture, then we do attach molecular testings with the same cytology sample. We always do a basic thyroid function test, although we know most malignant thyroid swellings usually are euthyroid. They are not hyper or hypothyroid. In addition to the usual evaluation, we also measure a serum calcium, get an ENT examination to assess the vocal cords, because when we do operations on the thyroid, the nerves that supply the voice box are very close to the thyroid, and we always make sure that the nerves are all right before we operate. A chest X-ray is done basically to make sure there are no, one is to see the neck, whether there is any tracheal compression, and also to look at whether there are any changes in the chest, in the lungs. Any patient who undergoes thyroid surgery has a thyroid anesthetic assessment, because we need very good anesthesia for these, and also monitoring during surgery and recovery. The other thing about malignancy in the thyroid is that we always have a multidisciplinary team that goes into this assessment of the patient. So we have the endocrinologist, we have the endocrine surgeon, we have the anesthetist, we have the nuclear medicine, and the oncology. So all of us meet together, discuss about each patient, because treatment for each patient is individualized. And then we make an assessment and decide what method of treatment we have to do. So just a word about ultrasound, because something that is done very often. So it helps to differentiate between a cystic and solid lesions, tells us about feature of malignancy, and also helps us to do an FNAC. And whenever you see the ultrasound report, usually you will see that word thyroids. Thyroids 1, thyroids 2, thyroids 3. That is just to tell you whether it is benign or suspicious or malignant. So whenever you see thyroids 1 and 2, you know it is benign, not to worry. 3 means mild suspicion, and 4 and 5 means you should definitely have to investigate them further. Now, when we do a fine needle aspiration cytology, there is a classification by which they go by. So if they don't get enough cells, they say it is non-diagnostic. Very often they'll say it is benign, which is what we see in 70 to 80% of our patients. And sometimes they sit on the fence. They say it is atypia of undetermined significance, which means they're not sure whether it is benign, but there is some area, some cells which are suspicious. In such patients, we go for higher testing, like we do molecular testing, or if there are other risk factors, like the patient is elderly or the nodule is hard, and then we straight away go for what is known as a limited resection, frozen section. So we remove half the gland, send it for a frozen section, where the pathologist will tell you the result in 15 to 20 minutes, whether it is benign or malignant. If it is benign, we stop with that. If it is malignant, we proceed with total thyroidectomy. This is just what I mentioned, that molecular markers are now available by which help us to tell us whether a swelling, which we suspect is malignant, but not sure on initial cytology, but this will tell, molecular markers will tell us whether it is malignant definitely or not. Now, what are the types of common cancers? The most common carcinoma we see is papillary carcinoma, which is about 70 to 80% of the thyroid carcinomas we see are papillary. And then we have other things like follicular carcinoma, Hürthle cell. Medullary carcinoma is one which arises from a separate type of cells within the thyroid, which are known as the C cells, and they produce a particular hormone known as calcitonin. And these can be familial also. And sometimes we have very aggressive carcinomas, which are known as anaplastic, where they progress very rapidly, and within a year or two, we may sometimes lose the patient. Lymphomas are also a type of cancer that occurs in many lymphatic tissues, but it can occur in the thyroid also. And these are very amenable to non-surgical treatment like chemotherapy. And very, very rarely we get cancers in other areas which come and spread to the thyroid, which is known as metastatic carcinomas. Now, treatment, unlike other carcinomas, as I mentioned earlier, the prognosis is excellent if treated adequately. And the thing in thyroid is it is individualized. Some patients have very small lesions which are detected very early. They may be less than 1 centimeter. In these patients, we just have to do a hemithyroid, which means remove half of the gland, which is whichever side the tumor is, whichever lobe it is, and just keep them on follow-up with suppressive doses of thyroxine. But whenever it is, very often when some of them are multifocal, or they may be lymph node involvement, or there may be metastasis somewhere else. In such cases, we always prefer to do a total thyroidectomy. And once we have a differentiated thyroid carcinoma and it is multifocal, there is a high risk of spread to other areas. We also give what is known as radioiodine ablation, which is a radioactive iodine which is given orally after 3 to 4 weeks of the operation. And that takes care of any microscopic spread or any active lesions anywhere else in the body. Once patient has had a thyroidectomy, they are on lifelong follow-up. They have to be on lifelong replacement with thyroid. And we do the yearly follow-up with the TSH and serum thyroglobulin, which is a good tumor marker for thyroid malignancy. Just to show you a sample, that's a patient who has had a total thyroidectomy. Both lobes have been removed along with the isthmus. And here you can find that we have done a total thyroidectomy with nodes which are there, which have been dissected. Multiple nodes have been removed along with the thyroid. So in conclusion, most important message is thyroid cancers are curable. So once somebody says thyroid cancer, no need to panic at all, because we know we can get full 100% curability in these conditions. And please remember, not all thyroid swellings are malignant. Only 10 to 20% of thyroid swellings are malignant. So there's no need to alarm if you have a thyroid swelling. And most important is you must go to your doctor, get a good clinical examination and imaging, because if there is a malignant lesion, early intervention is the best thing that you can do for these patients. And now with technology and everything available, treatment is possible with very minimal morbidity and zero mortality. Thank you.
Thank you, Dr. Nair, for that very in-depth presentation. And we already have lots and lots of questions that have come in. We're running short on time, so I'll straight away start taking them. But before that, one quick thing I wanted to ask you is there any statistics available that indicates that thyroid cases, disorders are on the rise now? And if so, why? And also, if somebody has a thyroid swelling which is not troubling the person, can they ignore it? Can they leave it?
I think so, because now I think main reason is one is the health the lifestyle modifications people have done now, so you get a higher incidence. The other thing is in imaging is so common now, rampant, that people are, because as I mentioned, 40 to 50% of people may have thyroid swelling, but they are never picked up during a lifetime. If you look at studies, postmortem studies have shown that 10 to 20% of postmortem studies show a thyroid nodule which appears malignant, but patient may not have a symptom at all. So it is only when you detect and you evaluate that you find really that they have, because only a small percentage in our country, only 10 to 20% present with malignant per se. 90% are detected incidentally, or they have a nodule which is not worrying at all, because the points we look for is whether it is causing any pressure symptoms. So if they have change in voice or difficulty in swallowing, then we know it is causing pressure symptoms. Although it is benign, it requires surgery.
Thank you. Dr. Pooja, based on your presentation, I think Ashmeen Abdullah Khan wants to know that whether young mothers, even in early 20s, would they get a pregnant women, would they get Or I mean, how would the thyroid problem occur?
If it is less than 20 years of age, very young pregnant women, then if they have a strong family history of hypothyroidism, thyroiditis, or they have taken medications in childhood, some risk factor is there, then they are at high risk. But every woman, irrespective of age, needs to have a thyroid function test checked at least once in the prenatal visit. If it is abnormal, then that needs to be followed up. If it is normal, then they don't have to worry.
Prasanna Lakshmi Raja is asking, how does thyroid function affect functioning of the heart? Dr. Sai, would you like to take that?
So the thyroid hormones have a direct effect on the heart. They act as a positive inotropic. They increase the contractility of the heart. So the pumping is increased. They also increase the heart rate also. So that these patients who have high thyroid hormones, they have palpitations. So increase in the heart rate. So if the heart rate increases further, it causes heart failure, where you have the pumping reduced suddenly and the patient develop the face symptoms of heart failure and pulmonary edema. So it has a direct effects which increases the contractility of the heart as well as the rate of the heart beat. Okay, these are the direct effects on the heart whenever the thyroid hormone is in excess. Whenever it is in low, the heartbeat reduces. So the patient will have bradycardia where the heart rate will be less than 70.
Rahul wants to know if stress is contributing in intensifying thyroid disorders. Dr. Tushar, if stress is contributing in any way?
Yeah, that's a nice question. As during my presentation also I said, during the stress time, no, especially in females when you talk about puberty and pregnancy, similarly, any stress also which will can stimulate the thyroid will need basically the higher thyroid hormones to take care of the stress. Mental stress as such alone may not cause thyroid problem as such. Okay. But in general, the physiological stress, especially in females, can, of course, will require higher amount of thyroid hormone for the body to function normally. So in those cases, of course, the pituitary gland, as Dr. Sai had explained earlier, will stimulate the thyroid gland to produce more thyroid hormones. So in these cases, you can definitely have enlargement of thyroid gland.
So there's a related question from Jasdeep Kaur, who says she's a 24-year-old student and a patient of congenital hypothyroidism. So how can she manage her stress levels being a student with long study hours?
Oh, she already has hypothyroidism.
Yes,
She is
that's what
on
she
treatment,
writes. Yeah.
and then she's on treatment. When somebody is on treatment, I think they are diagnosed hypothyroid cases. So they have to regularly monitor their thyroid hormone levels, like Sir had explained about the thyroid function tests, and take adequate dose of thyroid hormones. That should be good enough to take care of the thyroid problem. Okay. If they are on a treatment with a regular checkup, that should be under control. No need to worry about it.
She's asking how to manage her stress levels, being a student with
So
long study
Yeah,
hours.
yeah. That will need some input from other departments also. What I
yeah,
mean to say
so
that, of course, stress management is different, but when you talk about thyroid having problem like hypothyroidism or hyperthyroidism, we have to treat them medically. And once that is taken care, then I think the stress management, other people will also have role, like counseling or something. I mean, Dr. Sai will give
Would you
yeah.
some
like to
inputs.
add,
So yeah,
Dr.
madam.
Sai? Yeah.
Stress is an endocrine disruptor, madam. So stress can also be considered as an endocrine disruptor. So whenever you have a stress, so what happens is the patterns of sleep, everything gets disturbed. Whenever the sleep patterns get disturbed, these endocrine hormones are produced during particular timings of the day. So early in the mornings, most of them have a peak. Whenever you sleep disturbances happens, so these stress is going to alter the circadian rhythm, what we call it as the rhythm of the hormones being produced gets altered. So what she can do is she can follow a healthy lifestyle. So as she is already diagnosed, taking the medicine regularly on time and checking her thyroid function, as Tushar sir said, on the frequent intervals at once in 3 months intervals, she should increase the frequency of testing at that point in time. And then one more thing is follow a regular physical activity, which helps to reduce her stress levels. And having adequate sleep for 7 to 8 hours a day. This is going to keep her stress levels reduced and keep her thyroid functions under control. Whenever she checks frequently, she knows that whether the thyroid function is altered or not. Based on that, the dosage can be altered during the times of stress. This is what can be done.
One
The
more
healthy
suggestion.
lifestyle.
One more suggestion also
Yes,
is
sir.
that
Yes.
currently now this meditation and yoga, these are supposed to be very good. So in
Yes.
addition to all the medications, a little bit of yoga and meditation also will help to reduce the stress.
Right. And a healthy
Yes.
lifestyle, as it is required for, I think, preventing or controlling every disease. Asjad is asking, does thyroid disorder lead to infertility in males and females? Who would like to take that? Dr.
Yes,
Pooja?
madam.
Okay. Dr. Saya.
It's a link. In infertility, we do check the thyroid functions. If they are abnormal, that affects directly the infertility.
Okay. Dr. Sai, do you wanted
Yeah,
to add
madam.
something?
So
Yeah.
thyroid functions, hypothyroidism is going to affect the fertility. So the sperm counts are going to reduce, and the ovulation is also going to get affected with hypothyroidism. So always any patient with infertility needs to be screened for thyroid disease. If there is any minimal amount of thyroid disease, even the subclinical hypothyroidism, where you have thyroid hormones are normal and only mild TSH elevation is noted, these cases also needs to be treated in case of infertility. So the subclinical hypothyroidism also needs to be treated. And with the treatment, their ovulation will resume and they'll be able to conceive normally.
So we've talked about stress. So somebody wants to know, is there any connection between hypothyroidism and depression and IBS issues and how to handle it medically? Dr. Nair?
Yeah, the stress induces all the both hyper and hypo, especially hyper. Many patients who have a hyper who develop because of stress. I remember once there was a massive train accident, and following that, we had a series of patients who had hyperthyroidism. Similarly, people who have had problems at work, problems in marriage, and all that stress triggers, and many of them have hyperthyroid symptoms. And sometimes hyperthyroidism per se also can cause stress. That is, patients who are thyrotoxic, they tend to be angry. Mothers get more angry, beat their children. Patients, they have fights. So the higher level of hormone also increases. So sometimes when the patient is stressed, we have to make sure they are not thyrotoxic. It can be vice versa. Stress can cause this, and that also, hyperthyroid state also can cause stress. So it is important that we know that stress and a thyroid hormone is something that affects every function of the body. And so hypo or hyper can cause everything. Similarly, if the patient is thyrotoxic, they have increased bowel motion, they tend to lose weight, they get angry, they get upset, they have sweating, palpitations, all these can mimic other conditions also. But basically, so we know that thyroid functions are very important both for the normal functioning, and when they are abnormal, when they are hypo, you become slow, your activities, everything is slow. And when the function increases, you are hyper. They tend to be fidgety, they won't look you in the eye, they'll have tremors, palpitation, they get angry. And sometimes they are branded as psychotics. But actually, if you do a thyroid function, you pick up these conditions.
So, like, how many episodes of, like this palpitations or sweating or anger is required? Like, basically, what is the ideal time for doing a thyroid test? And somebody's also asking related, is it necessary to be fasting before doing the thyroid test?
Yeah, madam. So what happens is the palpitations needs to be present continuously over a period of time, and at least a minimum of a month or more is required. In case of thyroiditis, which we have discussed, where you can have a transient period. Normally, in case of hyperthyroidism per se, you will have the duration will be more than 3 months. Whereas in case of thyroiditis, the duration will be less than 3 months. So whenever the duration is more than anywhere between 2 to 3 months, it is crossing that, they needs to get tested for thyroid function test. On and off, because of the panic attacks also, you can have palpitations, which is different. It will be transient. It will subside by itself over a period of time. But in case of hyperthyroidism, what happens is it will be persisting throughout the day. So that is what it happens. And always the thyroid profile fasting is best time to do. But if the patient is not able to do it, so then the alternatives we can do it after food also. But the fasting is always very, very important, because in case of mild subclinical states, the fasting will pick up those mild subclinical states. In case of clinical hyperthyroidism and overt problems, it will be recognized even when you test after food also. But in case of mild cases, always fasting will be required.
There are actually multiple questions and repetitive ones about impact of thyroid on mental health of people. So if anybody would like to, maybe a little repetitive, but there are multiple questions on mental health, severe impact on mental health and resulting in anxiety, stress, and depression.
Yeah, as already has we have told that if it is hyperthyroidism, like Nair sir told, everything is increased. So in mental health, person becomes very irritable, very anxious, very angry. So for small things, they will start fighting. And as sir told very rightly, people think that they are psychotic, they have mental problem, but no, they don't have mental problem. It is just a mental impact which has happened because of disturbed thyroid hormones. Once we correct that, their mental state comes back to the normal state. They are not really agitated, but because of increased T3, T4, that is how they are behaving. And similarly, the reverse happens when they have hypothyroidism, when they feel lethargic, they feel lazy, they feel fatigue, they get tired very easily. We think they are lazy, they are not working, they don't want to work, but they are not lazy. It is just the thyroid hormones which are impacting them. So same thing happens like if a lady is pregnant and then the baby is also hypothyroid, especially in children. If they get congenital hypothyroidism, it directly affects their mental health, plus their mental retardation happens. Their slow growth happens while they're getting educated and they're learning. Their learning process gets delayed. So it has a direct impact on mental health.
And what are the side effects of the prolonged thyroid medication? And also, if there are any do's and don'ts while taking thyroid medication.
Yes, madam. Thyroid medications, well, you consider when the patient is diagnosed as a hypothyroidism and started on thyroxine. There are no, as such, no thyroid side effects for the thyroid hormones if the thyroid function tests are maintained well within the normal limits. If the dosage is over, or if the replacement is over, then the patient may develop palpitations and all these things. If the replacement is less, patient may develop bradycardia, that is low heart rates and all these things, constipation. So that's why after changing any dosage or after initiating therapy, at least after 2 to 3 months, his thyroid function test needs to be checked and see to it that the thyroid function is within the normal limits. If it is excess replacement is there, we need to reduce the dose. If the replacement is suboptimal, we need to make optimal replacement. That is why we advise all the patients to check the thyroid function test after 2 to 3 months of initiating the dosage or changing the dosage.
Yeah, I think a lot of doctors and medical students are also in the audience, and somebody's asked hypothyroidism patient, they need constant dose adjustments. So, how to handle it? So, if we have to,
Yeah.
Dr. Sanya says if we have to decrease dose of one thyroxine, how much we can decrease at once?
No, it is varies from patient to patient, and the scenario depends because each and every patient is different. So what we do is it also depends on the level of the TSH and level of the free T4 levels. We check every time in the thyroid as a part of thyroid profile. We see T3, T4, and TSH. Based on the requirement, we change the dosage. In the pregnancy, the dosage change will be more, whereas in the non-pregnant females or others, the dosage changes will be different. So it varies from individual to individual. So it cannot be generalized.
Yeah, actually, a lot of people have also stated their prescriptions, the medicines they are on, and they want to know whether they're on the right track or should they change it. I think we can avoid some of those. Meanwhile, Rohit Kumar is asking, maybe Dr. Pooja, you will take this. Why most of the time women suffer from thyroid problems at the time of puberty and pregnancy. So, which hormones are responsible for these two stages, and how should we come out of this situation? Interesting, because it's been asked by a guy.
Yes, that's good that they are concerned about the women health.
Yes.
Happens our human chorionic gonadotrophin, what we call in short term SCG, that increases, and estrogen also increases. So, because of high estrogen levels, women are more prone for getting thyroid problems. So, if once we know, we understand this thing, then we need to check, do the thyroid functions. If it is abnormal, we need to treat it.
Okay, Dr.
Just to add
Tushar, I
it,
think,
just to
yeah.
add it that what Madam says is correctly, exactly right. Only thing additionally, we have to know that thyroid has something called as estrogen receptors. So that is the reason where Madam said the high levels of estrogen will affect the thyroid gland also. So estrogen receptors are present on thyroid gland, and that is why thyroid hyperfunctions when there is increased estrogen level. So that is why the thyroid is more prone from the effect of other hormones. The thyroid itself has estrogen receptors.
And is biopsy always necessary for thyroid swelling, sir?
Yeah, when when you talk about needle test, FNSE, so that we do it when the swelling is suspicious on ultrasound, any family history of thyroid tumor, or in past history of any radiation. As sir had explained, the indication for FNSE needle test is when we high suspicion is there, like previous history of radiation, family history of malignancy. Ultrasound wise, as thyroid's classification sir had mentioned, if that is highly suspicious nodule, we do FNSE. The biopsy as such, when you talk about other tumors, like remove that part and do biopsy, is usually not necessary for thyroid gland. The FNSE is good enough to tell us whether the nodule is malignant or not malignant, so that if it is benign, we can observe that.
Dr. Nair, Nirmala Babu wants to know like whether thyroid medication can be stopped after a certain period. I mean, if the symptoms subside, and is there something like patient goes into remission and you don't have to continue with lifelong medication?
The thyroid medication, once it is started, if we have done a thyroidectomy, it's lifelong. But if it's for a benign condition like patient has got a thyroiditis or thyrotoxicosis, where we treat the condition, and then if they settle, we keep them on follow-up, and if the TSH levels are all right, they may not require supplements. But everything depends on how the clinical condition, whether they have any symptoms of hypo or hyper. If they are euthyroid, clinically, we monitor them with TSH, and if TSH is normal, within the normal range, and they are off thyroid medication, we can just keep them on follow-up. Especially when they are toxic, we treat the toxicity, and within a year, they become euthyroid. Then we just follow them up. And sometimes they get a recurrence, in which case we have to start medicines. Or in some conditions like thyroiditis, which is autoimmune disorder, some of them will become euthyroid, and they may not require medications after a year or two. But some of them with hypothyroid, with thyroiditis, the thyroiditis autoimmune may progress, and ultimately they may become hypo, in which case they will require lifelong treatment.
Mitra Dey wants to know if constipation and anal fissure is related to thyroid condition.
Yes, hypothyroid state definitely gives rise to constipation because the intestinal motility becomes slow. So there is fecal impaction, slowing of movement, fluid gets absorbed and feces becomes hard. And whenever feces becomes hard, as it passes through the anal canal, it tears the mucosa. That's what we call as fissure. So it's very common in hypothyroid states that they get constipation, and which gives rise to fissure, which is a very painful anal condition.
There's a question on diet. If you could all talk about the diet which is required. I mean, Dr. Pooja, you did mention in your presentation that pregnant women with thyroid should avoid cauliflower, I think you mentioned. And so if you could just give your inputs on what kind of diet needs to be followed.
We need to have iodized salt.
Not just for pregnant women, but generally for patients.
Yeah, iodized salt, then iodine-rich food like seafood, poultry, milk products, egg, yolk, especially yolk has got, then wheat, place things which have selenium or zinc. All the vegetables. We don't have to confine to one particular family of vegetables, like eating a lot of cauliflowers, we eat the pata gobi or the other types of cauliflower. So not excess of one particular diet, but having a mixture of everything. So I think that impacts. But we have to be careful, especially in people who are near the sea. They should ensure that they are not taking excess of iodine also. So excess of iodine also causes this Hashimoto's thyroiditis. And in North, where there are a lot of people who take iodine less or deficient salts, they are having iodine deficiency. So we have to ensure which region, part of the country we are in, and we should maintain the normalized values, not excess or deficient both.
Would anybody else like to add on diet specifically?
On diet, only thing is that certain food are known to be why this cauliflower, cabbage, and all these causes, because they have an avidity for iodine. So these foods, when you take whatever iodine is there in the body circulation, they absorbed. and that's why the goitrogenic effect comes. So it's not as such very important that you shouldn't take any particular thing. Any food in measured quantity is fine. Although some foods have this goitrogenic effect, they take up a lot of iodine from our system and they absorb that, and that's why we become they cause this goiter. So we shouldn't say that you could not eat cauliflower cabbage. Anything in moderate amount is fine. Excessive can cause this effect.
Does hyperthyroidism also affect eyesight, skin discoloration,
Yes.
placement of the eyes?
Because hypothyroid state can causes changes in the eye. They develop some deposits inside the eye, which causes the eye to bulge out. And ultimately that causes some deficiency in the vision.
Dr. Pooja, there's another question for you from Ankush Agarwal. If anyone is planning for conceiving and is taking thyroid medication for hypothyroidism, would there be any impact during pregnancy, and what could be done to plan better to avoid any possible health issues for the newborn?
Yeah, for this, if somebody is already taking medications, they have to inform the gynecologist. Gynecologist will get an endocrine opinion done, check the thyroid function done, antibodies checked, and then we have to adjust the dose, keep them in the euthyroid state. Euthyroid means the thyroid functions are normal in the blood when they're taking the medications. Like somebody is taking 100 micrograms in pregnancy, we may have to reduce or increase the dose. So that has to be checked every month. So every month we have to do the free T4 and report to the gynecologist or to the endocrinologist, and dose may need to be adjusted, reduced, or increased depending on that, not just one-time test. So if the thyroid functions are normal on medications, then pregnancy will be safe. So the outcome will be safe. But if they are disturbed, then that will impact the outcome or the baby both.
Dr. Tushar, how long can a benign thyroid swelling be observed without any intervention?
Yeah, as we discussed earlier also about indications of surgery or indications of intervention in a proven benign thyroid nodule. When we talk about FNSC proven benign nodule, unless there is causing a pressure symptom like change of voice, difficulty in swallowing, difficulty in breathing, some people having chronic cough, unless these problems are happening, the nodule can be safely observed. And of course, in history, if any family member has malignancy on that, also we have to check. But as long as the thyroid by ultrasound looks benign, and FNSC, if it is a proven benign nodule, and if it is not causing like compression problems like change of voice and change of difficulty in swallowing, it can be observed. That is not a problem.
So there's again a related question, that why do some individuals with benign thyroid swelling remain asymptomatic while others develop noticeable symptoms? And how can imaging techniques help differentiate between benign and malignant thyroid nodules?
Yeah, that's a nice question. Same thing. Basically, when you talk about benign thyroid nodule, when you talk about simple goiter, where it is caused because of the iodine deficiency. When there is iodine deficiency, thyroid hormone are not getting produced properly. So the pituitary gland is trying to make thyroid work more. So it is thyroid trophic, means it will increase the size of thyroid also. The number of cells will become more, as well as they become bigger in size. And after some time, there is a lot of growth of thyroid cells, and there is something called a central bleeding and necrosis of those glands. So they form nodules. Initially the thyroid increases in uniform way, and then slowly some nodules will develop. They are not cancers, but they are nodules in the thyroid which are benign. So when some this stimulus of thyroid gland is more and more, the thyroid nodule can grow. Whereas some patients, if the early intervention is done by medicines, this thyroid stimulation will be less. So this growth of nodule will be less. For some patients, the stimulus continues and the thyroid nodules will become big in size. So that is why for some it is, it will remain small, will not cause problem. For some, it will increase in size and cause troubles.
So Hema, sorry.
Yes.
No, so Hema Bindu is asking how to identify the tumors in initial stages in asymptomatic patients.
Yeah, the ultrasound is a good way of doing it. And of course, the radiologist will give us good information whether the nodule is taller than wider, whether there is calcification, any cyst formation. So these features are quite informative about whether this is benign or malignant. So a serial ultrasound can be helpful to identify whether any benign is, whether it is benign or becoming malignant. And FNSC of a suspicious nodule, if that is benign, then we can very well manage them without any intervention.
Dr.
Serial
Sai, maybe.
ultrasound and a good FNSC should be sufficient to assure the patient that they can observe the nodule.
Dr. Sai, maybe you could take this from Pritika, who says, after a total thyroidectomy, how does the body adapt to the absence of thyroid hormones? And what role does peripheral tissue play in converting synthetic T4 into active T3 for normal metabolic function? And also another related question is, what are the risk factors after doing total thyroidectomy in diabetic patients in particular?
So after total thyroidectomy, there is a complete absence of the thyroid. So once after that, the half-life is around 7 days. After 3 T halves, no, after 21 days, there will be complete absence of the thyroid hormone. So we need to start the replacement within 3 weeks. So we will start the replacement with the thyroxine, and after that, we'll follow up with the serial thyroid function test till the thyroid function is normalized. So based on the dose, based on the body weight, we prescribe the dosage. For everyone, it is 1.6 micrograms per kg body weight is the requirement. Based on the dosage, we'll prescribe the dosage initially, and after 6 weeks, we'll see the thyroid function test. If the dose is not sufficient, we'll update the dosage and achieve the euthyroid state, which is called as a normal thyroid function. And in diabetics, there is no specific things related to this, but only thing is we need to maintain the normal thyroid function. That is one thing which is important. And we also, any relative symptoms related to the other injuries which is happening during the thyroidectomy also needs to be looked into. I think which was focused by Sir as a part of thyroidectomy, they measure the calcium levels also. If the patient is having any other symptoms, we also look into the calcium replacement. If anything is required, we'll do that also.
And what are the impact or effects of hypo and hyperthyroidism on neonates?
So hypothyroidism in a neonate commonly presents with feeding difficulties initially, and later on there will be a delayed growth and delayed eruption of the teeth, deciduous teeth. So the temporary teeth formation also will get delayed. Initially, the patient is not able to pass the stools even after 1 week. Normally, 3 to 4 days is okay, but after 1 week also, they will not be able to pass the stools, these babies. So at that time, we tend to pick up these things. Nowadays, screening programs have been, universal screening programs have been developed by the Endocrine Society. So every neonate should be screened for a thyroid function test to look for any thyroid disease, which should be done after the birth of the child, after 48 to 72 hours after the childbirth, so that we can pick up them early. Because later picking up the thyroid disease later will help in the poor development of the brain. So the child may develop mental retardation if you pick it up later. So always screen early and try to treat early so that the brain development is not affected. So if you treat early, the child will be as normal as the other any other child. So if we don't treat it early, the brain development gets affected, which leads to mental retardation. That is the most important thing, and the growth also gets affected.
Dr. Nair, Naga Raju wants to know that when thyroid medications dosage is increased, the gut health gets affected and bloating problems occur. So how to handle all this?
No, the important thing is when we are replacing the thyroid hormone, we have to monitor the TS. As I told you, in higher level of thyroid hormone, you give more thyroxine, the gut motility increases. They have this feeling of bloating. That can be there in both hypo and hyper. But in whenever you are replacing, we can always adjust the dose and make sure that the levels are. So the moment they have these symptoms, you reduce the dose, and we reduce the dose in a very slow manner. Suppose the patient is getting 100, we'll make it 85.5 and then see how they are managing. So it has to be fine-tuned according to that, and at some level they'll feel they are very comfortable. And again, TSH gives us a very good idea. So TSH is usually about 0.5 to 4.5. That is the ideal. So once the TSH is more than 6, 7, we know they are giving subclinical hypo, and we compare with T4 and T3 at the same time. So you do TSH. If it is less than 10, we usually wait for the T3, T4 level to be abnormal before we treat. But if they've got symptoms, and then we check T3, T4, if they are borderline low or just lower limit of normal, we give them small supplements and their symptoms subside. So it's hormone is a very interesting thing where we can very easily fine tune and symptoms can be corrected very fast.
Right. I think we are already past our time of the program. One last question, again related to diet, from Binod Barik, who says that why doctors advise hyperthyroidism patients not to take food like coconut water, curd, oranges, etc. Does it have any relation? So
We don't
go
recommend
ahead.
any patient, madam, regarding any specific diet for hyperthyroidism.
Mm.
I think some alternative medicines might have recommended those things, but we never recommend any specific diet for hyperthyroidism. For hyperthyroidism, taking the medication on time, having the checkup on time plays an important role.
Right. I think with that, we'll kind of end the webinar on thyroid disorders, early detection and prevention. I would like to thank all our panelists for their valuable inputs and for reiterating the message of early detection and prevention. And I'm sure the audience would have also found a lot of important takeaways. This webinar was presented by Naruvi Hospitals, Vellore, in collaboration with The Hindu under the Healthy India, Happy India initiative. I thank you all doctors and the audience once again for joining in.
Thank you.
Thank you. Thank you.
Thank you, sir. And once again, happy Republic Day.
Thank you.
Thank you.